The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone. Thanks for joining us today for our webinar. It's a really sunny day, and we are so glad to have you with us. My name is Carmen Boone. I'm an education coordinator from Oregon Pacific Area Health Education Center, a hosted agency of Samaritan Lebanon Community Hospital. Our agency mission is to promote access to quality healthcare through community and educational partnerships. Today, I will be your host and moderator. Let's go over some housekeeping items. On your GoToWebinar control panel, you will notice that all microphones are muted. They'll remain muted during this session. Please use the questions menu at the bottom of your panel and type your questions and comments at any time. We will be monitoring them throughout the presentation. This webinar is being recorded and will be available on our YouTube channel. The slides can be downloaded from the Handout menu. If you have any trouble downloading them, send us an email and we'll send you the slides. If you have any questions or trouble, please email me at Carmen, B as in boy, @samhealth.org. To obtain CME credit, contact hours, or certificate of attendance, you must log into www.eeds.com and enter this activity code. Please write it down for your records and consider that it expires in 1 week. We will email you these instructions and links today within an hour or two after this webinar. This presentation is jointly provided by Oregon Pacific Area Health Education Center and Samaritan Health Services. And the presenters and the planners of this activity report that we have no conflicts of interest or relevant financial relationships with any commercial entities that might affect the contents of this presentation. And this webinar is presented by Dr. Iwan China. He was born in Saskatchewan, Canada. He is board certified in family medicine in both Canada and the United States. In his free time, he enjoys spending time with his family, reading, physical fitness, music, and theater. Dr. Iwanchina also serves as the Chief Medical Officer for Samaritan Health Plan Operations. We are very happy and honored to have him with us today. And now, without further ado, let's go with Dr. Iwanchina. I'm going to start his slides right now.
Thank you very much, Carmen, for that introduction. And I wanted to also say thank you to the Oregon Pacific Area Health Education Center and Carmen, and also my friend Stephanie at the Samaritan Cancer Resource Center for the kind invitation. The other disclosure that I wanted to make, I don't have any conflicts of interest, but it is important to note that I am a paid employee of Samaritan Health Services. And as a family physician, I am equally excited about preventing disease through different initiative of which we're going to discuss today. So the screening for colorectal cancer is of utmost importance, but we're going to outline some of the deficiencies that we've actually seen since COVID-19 has come upon us. Next slide. So our objectives today, I first want to have you understand what a clinical screening is about. We use the word screening a lot, and what actually makes up a good screening test. And then we're going to understand the impact of COVID-19 on colorectal cancer screenings that we've seen. We also want to then understand the importance of resuming CRC screening, address any hesitancies that might be there, and then look at what the updated colorectal cancer screening guidelines that just came out from the United States Preventive Services Task Force have recommended to us. Next slide. So first, just a little bit more about my personal background. We can go to the next slide. But I'm a very relationship-driven person, so I like forming relationships with each and every person, even though we're doing this virtually today. But if you can still hear a little bit of my Canadian dialect, I was born and raised in Saskatchewan. which is the Prairie Province right above Montana and North Dakota, and received my Bachelor of Science in Anatomy and then also my medical degree at the University of Saskatchewan. And I chose family medicine, and unbeknown to many other specialists that are in the practice of medicine and surgery, many people that choose internal medicine, pediatrics, family medicine, those traditional primary care-based residencies and programs actually make this decision by choice. We really believe in the prevention of disease, not only the treatment of the disease state, but primary care specialties are very relationship-based as well. I was a medical officer with the Department of National Defense in Canada, so I wore a uniform for many years and served on a military base in just outside of Medicine Hat, Alberta. But it was at that time that my wife and I wanted to escape the prairie snow. We had had enough of 6 months of winter and wanted to keep heading southward, and came upon Oregon. My sister-in-law from my same medical school was already in Roseburg practicing. We came to visit her a few times and just fell in love with the state. And fast forward 23 years, and I've been with Samaritan Health Services ever since. I'm still a practicing physician with urgent care, but administratively I've held many positions within the organization, and currently am acting as Chief Medical Officer of Samaritan Health Plans and Intercommunity Health Network Coordinated Care Organization. And since the pandemic just previously began, I have been holding the position of the president of Oregon Medical Association as well. And that will term in September of 2021. Next slide. So what we're going to look at here is activities that all give the definition of a good clinical screening. And this dates back to 1968 when Wilson and Jugner wrote a paper of what a good clinical screening test is. The World Health Organization also adopted this. So as I'm going through these different definitions and terms, I want you to all think of the different things that we're doing today in the practice of medicine and whether it actually meets the definition of this good clinical screening. First and foremost, the conditions sought should be an important health problem. So as it relates to colorectal cancer, we're going to see some data later that defines that, yes, this is a worldwide problem, a national problem, and this is a condition that is an important health condition, not only because of its prevalence, but because of its cost to all of us in society. Second, there should be an accepted treatment for patients with a recognized disease. Colorectal cancer fits that. If we can identify polyps that could turn into colorectal cancers early enough, they can be removed. And this actually is a life-saving measure for a person with polyps or even early cancer of the colorectal disease tract. Next, facilities for diagnosis and treatment should be available. And we know that our facilities, whether it's primary care outpatient or hospital-based procedure rooms, GI suites, etc., we all have these available in our region for this good diagnosis and treatment. Not only with colonoscopy, we're going to walk through some of the other ways that we can screen effectively for CRC. Next slide. The next term for good definitions of good clinical screenings, there should be a recognizable latent or early symptomatic stage. And there can be some of this with change in bowel movements with colorectal cancer, the screening for any blood that may occur before we can see it with our eyes itself. So there is this latent symptomatic stage that can occur with CRC. Next, there should be a suitable test or examination. There's many suitable tests. Not everybody likes to go through a colonoscopy. We're going to discuss the other tests that are also available to us for good CRC screening. And the test should be acceptable to the population. Now with colonoscopies and the prep, it is done with as little inconvenience as compared to several years ago, a decade ago. I can raise my hand and state that I went through my first colonoscopy a few years ago. And outside of the annoyance of drinking the prep, the test itself was amazingly done so well. And I had very little residual after effects and actually can't remember the screening in the first place because of the sedation that was used. So we need to do our job appropriately by talking about our experiences with our patients so that they can understand that it's not as scary as we once thought it was. But then next, the natural history of the condition. Going all the way from development to latent to declared disease, we need to adequately understand that disease. And we do know enough about CRC today. Next slide. The last few elements of a good clinical screening, we should have a policy on whom to treat as patients. And there has been a lot of consensus statements from the American Cancer Societies, GI fellowships and specialties that look at CRC screenings and have good agreed upon policies, as well as recommendations from the United States Preventive Services Task Force. The cost of case finding, so that diagnosis, that treatment of the patients diagnosed, we got to look at this in terms of economics and really look at the whole expenditures of medical care as a whole. So we'll go into a little bit of this in terms of our screening tests as well, and why it makes good sense to do upfront screening versus the cost attributed with CRC. And then case finding. This has to be a continuing process. It's not one and done. You don't screen once and then forget about that screening for CRC later on with your patients, and we'll talk through some of that. Next slide. So the most important thing of good clinical screenings is it doesn't focus on just the test itself. We really have to appreciate the whole context in which we utilize these tests and discuss that context with our patients. And these criteria that have been developed by the USPSTF really have to further have further discussion with patients. This is not intended to be that one final answer. This is intended to have a series of discussions with our patients. And it is just a series of discussions by all people on the healthcare team, not just the clinician. But for example, if we detect a disease or an abnormality, does it always improve the health outcomes that we want for our patients? And we can only look at the example several years ago when we were thinking it was the right thing to do for a full body MRI and absolutely screen everybody just in case it was able to pick up something. And we found that the opposite was true. This led to the diagnosis of a lot of quote unquote incidentalomas, things that were seen as abnormal on an MRI that then led to more treatments, more procedures, sometimes invasive, and adverse outcomes, and really didn't give a good clinical outcome to the health of our patients. So this crucial question we have to look at with screening, does the screening test lead to an overall better health? And we can absolutely say that this is true with colorectal cancer screening. Next slide. So let's talk about colorectal cancer just as a background. Next slide. This is the third most common malignant neoplasm in the whole world, and it's the second leading cause of cancer deaths in the United States. And we estimate that in calendar year 2021, there will be about 149,000 plus new cases of colorectal cancer diagnosed, and unfortunately 52,980 deaths that are predicted in calendar year 2021. And we can do a lot to change the trajectory of these deaths for the future. The incidence of colorectal cancer is higher in men than women. And this is key when we look at the updated recommendations from the United States Preventive Services Task Force, that 78% of cases of CRC are really diagnosed in people age 55 and older, but about 15% of cases we see in the age group of 45 to 54 years, and thus the change in the recommendations. The main risk factor for CRC is increased age. We can't do anything about that. We also do see that there is a double risk of colorectal cancer with a first-degree relative that has already had CRC. Next slide. But the high cost of colorectal cancer is upon us. We know that based on US dollars way back in 2010, so a decade plus ago, we were spending $14.1 billion in the United States for annual medical costs of CRC care. This was annual medical costs. So if we times that by the last decade, you will see well over $140 billion plus that have been spent on the costs of treating colorectal cancer. 11% of all cancer treatment costs in the United States are for CRC, and it is the second highest cost of any cancers in the United States. If we look at the average Medicare healthcare spending for patients that have a new diagnosis of colorectal cancer, this will range in 2013 dollars, so it's gone up since then, but the data we have from the Medicare study puts this range from about $40,000 to $80,000 per patient, dependent on their stage. And on average, cancer survivors do have annual losses in work productivity due to missed work days, employment disability, and their costs are about $1,000 higher compared to people without a cancer history. We do know that some cancer survivors are unfortunately not able to return to work at all, but many others are not able to perform all of their tasks because of residual illness, residual distress. Next slide. So let's talk a little bit now about colorectal cancer screening in general, now that we've understood the context of the costs associated with CRC. We want to ensure we are being upfront as much as possible, and we will go through the different screenings that are upon us, as well as the costs that are attributed with each of those screenings. Next slide. So when we look at the United States Preventive Services Task Force recommendations, the recommendations for colorectal cancer screening specifically give a grade A recommendation for screening all adults aged 50 to 75 years for CRC. This has not changed from the new guidelines. They've always put this as a grade A. But the new change was now a grade B recommendation to start screening of adults for CRC at age 45 to 49. And then there is a grade C recommendation of the ability to selectively screen any adults that are 76 to 85 years for colorectal cancer. You have to consider their overall health, their prior screening history, and take into account, of course, the patient's preference. Patient-centered care and decision-making is very, very important. Next slide. This will tell you a little bit about what these grades mean, grade A, B, and C that we just talked about. That grade A being 50 to 75 screening, the net benefit is really high. We see a lot of good return on that investment from screening in this population. Grade B recommendation, this is age 45 to 49. The net benefit is moderate, but it's still a good net benefit. So this is why they've given it a grade B. And grade C, the net benefit is small in screening in the population based on their history, based on their desire of age 75 to 85. There still is a net benefit. It just is, however, smaller than the higher moderate benefit. And that's why the USPSTF gave this a grade C recommendation. Next slide. So what are the different tests we can do with our patients? We still utilize the high-sensitive guaiac fecal occult blood test. This is a change from years previously that was just the stool cards we had in our offices. It's now a high-sensitive test, and you have to ensure that this is done annually. We also do have the fecal immunochemical test, or many of us refer to as the FIT test, and this also has to be done annually. One of the benefits of the FIT is we don't have to be as restrictive with reduction of animal protein in our diet prior to testing with the FIT, where you still have to do that with the high-sensitive guaiac fecal occult blood test. But there has been the emergence of the stool DNA FIT test, and this has gained some increased adoption over the last few years, and this we can do every 1 to 3 years based on the evidence. CT colonography, or what we refer to as a virtual colonoscopy, can be done as a screening every 5 years. We can still do the recommendation of the flexible SIG every 5 years, or then a flexible sigmoidoscope every 10 years, plus then the addition of an annual FIT test. And then we have that gold standard that if we wanted to actually remove polyps while we see them, we could have that colonoscopy screening every 10 years. The most important caveat of any of these recommendations that you see upon us is consistency in screening. So next slide. And this is that qualifier, that all of these possible tests for screening for CRC has to acknowledge that the patient in front of you is at average risk for colorectal cancer. If they are not at average risk, if they have already had cancer, already had polyps, they do not fall into the screening bucket any longer. So we have to ensure that we understand what the average risk is. They haven't had a prior diagnosis of CRC. They haven't had a prior diagnosis of adenomatous polyps, or they don't have a prior diagnosis of inflammatory bowel disease, because we know that ulcerative colitis, Crohn's disease, does increase the risk of having CRC. Also, average risk means that they haven't had a personal diagnosis or family history of these known genetic disorders that can predispose them to a higher lifetime risk of colorectal cancer. So we're talking about syndromes like Lynch syndrome, also familial adenomatous polyposis. Next slide. And that other qualifier about screening, that no matter what type of test that we utilize, this is only about that future risk of CRC, that traditional screening for that average risk patient. So again, if we see a patient has an increased future risk of CRC because they now have had a polyp removed from their colon via colonoscopy, or it's been a tubular adenoma or any of the sessile serrated adenomas or multiple adenomas, then screening falls out the window. They are in a surveillance mode, and we can't screen these patients with those tests that we just previously went through. And that's really, really important to remember, that screening versus surveillance. These people fall into the surveillance category. Next slide. So again, adherence to any of the screening method is going to be key. If you choose in your offices to do FIT testing, you have to ensure that it's done annually. And key to that would be the production of a CRC registry in your electronic health records, so you can track those individuals appropriately and so they don't get lost out to getting that screening on an annual basis. We actually have to remind patients for this from a registry perspective, instead of relying on the patients to remember when they last did their FIT test. Because if you go from personal memory from any of us, something that we think happened a year ago probably happened, in fact, 3 years ago. We found through a well-conducted randomized clinical trial that if even we look at the uninsured population, a FIT outreach program and a reminder phone calls did give an adherence rate of 40% in this group, compared to a usual adherence rate of 12.1%. So the more that we can do with that registry and that reach out to patients and that documentation of their FIT test, that follow-up phone call, follow-up mailer, we'll talk about some of those strategies a little later. But key in improving our rate of detection of CRC is improving the rate of the screening. And FIT, we're going to see through some of the studies, has actually potentially emerged as one of those options to really adhere to in this COVID time period and even post-COVID. Next slide. So the average cost of colorectal screening options, the occult blood test, high sensitive, or the FIT, fecal immunochemical test, run on average about $3 to $40 a test. The fecal DNA testing is $400 to $800 per test. Virtual colonoscopy, $750 to $2,000 per test. And you can see then for sigmoidoscopy and the convention colonoscopy, it's running on average $2,000 to $3,750 per test. Next slide. So future state, this was a really interesting study that they did in an Asian country where they built a stratification system that was based on age, gender, smoking, family history, and that family history of CRC. So they have to exclude those high-risk families that have Lynch syndrome, adenomatous polyposis coli, but then they risk stratified along with utilization of the fecal immunochemical test to really detect, well, which patients out of this whole profile need a colonoscopy, which ones need to be recommended for further adherence and watchful waiting later. And so if the stratification system or the fecal immunochemical test was positive in this cohort, then the individual did receive that colonoscopy recommendation. And what they found later on was 95% of people that had colorectal cancer were actually correctly told to have a colonoscopy. So in this time period where we have to start thinking of some of the costs that we're doing in today's healthcare system, it gives a mind to maybe look at some of the cost-effective ways of screening and maybe better utilization of higher cost colonoscopy to try to reduce those overall costs in the healthcare system. So it gives some future state consideration. Next slide. This slide is intended, I'm sorry about the print itself, but this is really kind of showing the magnitude of the effect on colorectal cancer incidence and mortality. And the first row you'll see is the fecal occult blood testing. And you'll see the magnitude on the reduction on the incidence of CRC is likely small to none when it comes to occult blood testing. And the incidence on the effect of mortality is running between 15 to 33%. If we look at the FIT testing specifically, then we have about fair magnitude on the effect of colorectal cancer incidence and a fair magnitude on the effect of mortality itself. And similarly, when we look at sigmoidoscope, we have about a 20 to 30% effect on the magnitude of incidence on CRC, with anywhere from a 27 to 31% effect on the mortality for distal colon cancer. The thing to remember with this, there are still surprisingly many patients, and there may be many clinicians that still feel that an office-based digital rectal examination is an appropriate screen for colorectal cancer. And this really does not have any effect whatsoever on the incidence or the mortality of colorectal cancer. So if some of your patients think that that is a useful way to screen for CRC, please have that conversation with them. And if this is news to you as a practicing clinician, that we no longer should be using DRE as a form for screening for CRC, then please change your practice style. When it looks at colonoscopy at that magnitude of effect on CRC incidence and mortality, it is both high upwards into 60 to 70% magnitude of incidence reduction, and more so for distal colon versus right side colon. Next slide. So now we're going to talk a little bit about, what has COVID-19, this whole pandemic that we have been thrust into, done with colorectal cancer screening. Next slide. So it really is an understatement that COVID-19 has really challenged efforts all across the healthcare system in all screenings, not just CRC. And it's really highlighted some of the inequities that we have from different populations, people of color, disadvantaged populations, marginalized populations, people without insurance, and those inequities of colorectal cancer itself and those outcomes related to the cancer. And rightly so, back in early 2020, CMS, the Centers for Medicare and Medicaid Services, along with the American Cancer Society, did make recommendations to start to delay all non-urgent care urgent procedures. That was the right recommendation for that point in time because we did not know what COVID-19 was going to do to the healthcare system. There was patient fear in entering into the institutions. There was clinician fear in still entering into the institutions because we didn't know what this was going to do. So it was the right recommendation at that time. Now we are seeing some of the fallout that occurred from those right recommendations. Next slide. So if you look at just COVID-19's impact on family medicine visits, this was studied in the state of Michigan. And you will see in the rows that you will see are several months in calendar year 2017, 2018, 2019, but the very last row on the right side is what happened with family medicine visits in May to June of 2020. And you will see that the in-person visits fell dramatically from 22,000 visits per month that we were seeing to 2,000 visits per month in March, and 1,400 visits per month in May. And that was just in one month's time period. We saw a dramatic decrease in any of those in-person visits. Many clinics closed their doors because they were scared of potentially causing vector spread to other patients with CRC just by mere being in the examination room and being in the waiting rooms. But what we saw correspondingly was a huge increase in the amount of video visits that occurred with patients, going from a 2% per month in 2017 to 2018, going all the way to 3,500 video visits in a month, or 35% of those visits being done by televideo. We saw a similar corresponding increase in the amount of phone visits that were being performed. And luckily, a lot of the insurers in the nation and in the state of Oregon were paying clinicians for video visits and for telephone visits. And that was the right decision to make at that point in time. We also saw a big increase in adoption in patient portals, and also the total number of visits really did decrease overall, but we saw a corresponding jump in those in-person visits and video visits and telephone visits. So next slide. What this did with COVID-19, we have a lot of concern that because of patients not coming into the exam rooms to talk about screening in the first place, that this will lead to missed and advanced stage colorectal cancer diagnoses, and unfortunately excess deaths from CRC in the next few years. And we also worry that this burden is not going to be evenly distributed because of screening disparities by communities and populations that have been disadvantaged historically and present day and into the future state. So there's a lot of concern about those excess deaths broken down by subpopulations. Next slide. So initially, what did we see in those first few months after COVID occurred? Comparing mid-April 2020 to mid-April 2019, there was a 90% drop in colonoscopies. And then we also showed that that led to an estimated missed or delayed diagnosis of colorectal cancer just in a 3-month time period from March to early June of 1,800 plus delayed or missed diagnoses. The initial impact as well was 1.7 million missed colonoscopies. So we didn't get the opportunity to remove any of those early polyps that could have been performed. And also this was missed opportunities of revenue for healthcare systems as well, and we can't ignore that. But we do feel that there's going to be about 4,500 plus excess deaths from colorectal cancer over the next few years due to those missed opportunities of screening. Next slide. This was in the journal Stat, and Dr. Fola May, who is a physician with David Geffen School of Medicine and UCLA practicing, gave a slide presentation to her colleagues. So I took this information from her very useful presentation. But in the Stat magazine, it showed that routine cancer screenings overall did decrease during the pandemic. And for cancers of cervix, colon, breast cancer, they were all down between 86% and 94% in the month of March compared to the average 3 years prior to COVID-19. Next slide. And Dr. May also showed that in her home site of UCLA Health, they showed a correspondingly decrease in screening colonoscopy by a 90% decline. And you can see this in the red arrow that's identified. If you see in the next slide, you'll see the exact same rates did occur with US data as well. Those colonoscopies dropped nationwide by about 89%. Next slide. So because of that drop in colonoscopy, we did see a drop in the diagnosis of colorectal cancer. And we see that that decreased by about 1/3 across the whole United States. Next slide. You'll also see that because there was less colorectal cancer being diagnosed, there was a corresponding decrease of colorectal cancer surgery as well. And this decreased by about 53% across the whole United States. Next slide. If we look at some of the data that was looked at in the Journal of the National Cancer Institute, they looked at real-time pathology reports that were in cancer-based registries that some systems had. And they found that there was a 10% decline in the pathology reports that were flowing into just those cancer registries from 2020 compared to data in 2019. And so they really ensure and stress to us the continued monitoring and evaluation of the effects of the pandemic on cancer staging, survival rates, socioeconomic status, that geographic disparities, and access to care is going to be of utmost importance for the years ahead of us. Next slide. In JAMA, an oncology study looked at the national screening rates for prostate cancer and breast cancer, and they found that these rates were actually starting to bounce back to pre-COVID levels by about July of last year. But colorectal cancer screening rates did not. They are staying at about 13% below those 2019 rates. And we've also seen that these declines will differ based on geography, social economic status, but I'm going to show that there's a compelling utilization of telehealth. And this could be associated with higher screening rates in order to get us back upwards on that trajectory. Next slide. If we look at the flow diagram of what happened with COVID-19 and its disruption on CRC screening, we'll see on the left-hand side of the slide that there are various healthcare factors that were at play. We were limiting the amount of elective procedures that were being utilized, but this could give then an increase in stool-based testing. Also, it could allow us to start to prioritize those screening based on that individual risk profile, going back to that study that we had talked about that was done in Asia. Also, we know that there is going to be a lot of backlog of patients now that are all awaiting screening colonoscopies, and we're not going to be able to get them in quick enough. And so it gives us pause to reconsider some of those stool-based testings. And those stool-based testings then can be done in the luxury of a person's own home. If we're looking at some of those patient factors that were at play during this COVID time period, that fear of exposure with in-person screening is still alive and well in our patients. Also, the genie is out of the bottle when it comes to telemedicine. Many of our patients really like this modality of care, and we don't see it going away now that we've started to utilize it. Again, looking at that stool-based testing, if you looked at preference only, many patients will prefer to do a stool-based testing versus go through with the colonoscopy. And there's still a lot of concern about testing protocols, PPE that is utilized in the clinics, outpatient surgery centers. We now don't feel that there is a shortage of PPE, but that was one of the patient factors that was at play previously, that if clinicians were being short of PPE, were they going to be exposed to those clinicians because of inadequate safety supplies? But lack of insurance and money is also a patient factor that we have to consider. So again, it brings to mind that resource allocation to potentially increase other screening modalities like FIT. Again, worsened disparities due to decreased awareness, and we'll talk about a tribal health center that did some innovative modalities to increase FIT testing in their communities. But this really gives that ability to also discuss and bill appropriately to insurance companies that CRC screening modality via virtual medicine, so telemedicine, telephonic care. We're still able to bill appropriately for those services today. Next slide. So there was a group of people that did a journal in the Journal of American Medicine this year in 2021, where they did a simulation model looking at the reductions in care utilizations due to COVID-19 and came up with an estimated 1.1 to 2 million fewer colorectal cancer screenings. And utilizing this simulation model, they then predicted that there would be about 8,300 to 12,000 fewer CRC diagnoses, and then 6,000 to 9,000 fewer early stage colorectal cancer diagnoses between calendar year 2020 to 2023. And then what they did with that simulation model, in the next slide, you'll see that they looked at just an abbreviated period of reducing colorectal cancer screenings, and in that abbreviated time period, increased the amount of FIT tests that were used and associated. What they found was there was an additional 588,000 CRC screenings that were done in this abbreviated time period, of which 68% of the colorectal cancer diagnoses were actually considered early stage. The next slide shows they did this same simulation model, but over a prolonged period of time. And they found that increasing the use of FIT was associated with an additional 655,000 colorectal cancer screenings and 2,700 CRC diagnoses. And 71% of those were actually early stage. So going back to those screening definitions that we talked about before, we want to ensure a screening will help identify a disease state at an early stage so we can actually still do something about that. And early stage cancer removed effectively with adjunctive treatment still has a very, very high 5-year mortality and beyond. Next slide, next slide. So in the simulation model, the results they showed was if we had an increased use of FIT during this time period of COVID-19, that they saw an association with increased screening, participation, more patients utilized that methodology, and more CRC diagnoses came out at earlier stages. So if we estimate that out in real world clinical practice, we do know that increasing FIT-based CRC screening participation during this time period really could mitigate the consequences and make up time for those reduced screening rates just in those first few months of the pandemic. Next slide. So future opportunities to start to explore. Next slide. We've talked about registries already, and those that are working in electronic health records like Epic. Every Epic system is different. If you've seen one Epic, you've seen one Epic. And that goes to the same is stated for any of the other electronic health record systems. But the key to doing a good job of cancer diagnosis and screening is to really create those registries. Going back to all those different recommendations of the United States Preventive Services Task Force for CRC screening, it's only as good as the keeping up with the annual screening for FIT, for example, or the 10-year screening for colonoscopy. You need to build in those timeframes in your registries, because if you depend on clinician remembering or patient remembering of their last FIT test or their last colonoscopy, it's really, really hard to do that without the use of registries. And how you leverage registries as well to push information utilizing MyChart portals, for example, so that patients are aware of their need to do a next FIT test or scope, etc., is really key with leveraging that registry and leveraging the electronic health record to make it work smarter for us instead of harder. And so team-based screening as well. We talk a lot about the clinician part of team-based care, but many of our medical assistants, nurses, community health workers can also assist in telling the message of the importance of screening. It's also important when we're talking with various populations, discussing this with a cultural relevance. We do know from the data in Oregon that the Latinx population is screened for CRC at a much lower rate compared to white Oregonians and African-American Black Oregonians. So talking with our Latino population with that cultural relevance, that community health worker that's from their community, is key in helping to address and adopt enhanced screening. We talked already about some of the avenues upon us for telemedicine screening, and the fact that commercial insurers, Medicaid, Medicare, does pay for telemedicine, will continue to pay for telemedicine. And from a patient adoption perspective, many patients really like that opportunity to discuss their care plans and screening opportunities via telemedicine. But we have a unique opportunity to keep collaborating with our gastroenterologist specialists, and how we collectively do this through our registries, their registries, so that patients aren't getting multiple bombardments of messages for screens from various entities. We really want to try to maximize the experience to the patient and try to create a standardized communication platform that is seen for the patients as easy to use, easy to navigate, without a lot of barriers. We also have the ability to collaborate with our local cancer resource centers. We do a lot in tandem with education about various cancers and how to screen appropriately for that. And our local cancer resource centers have a whole host of information inside their resource centers and on their web pages for our public to utilize. And then again, that future opportunity of that utilization and adoption of FIT at home, fecal immunochemical testing in the privacy of your own home, has been shown to increase the amount of CRC rates. Next slide. So this was a study that was done with a tribal health clinic, and they looked at their patient population age 50 to 75 years that was not up to date with a CRC screen. And again, they were average risk because they didn't have a previous history of CRC. They still had a full colon intact, and they separated them into 3 groups. The groups that just had that usual care, going from memory, going from patient visits coming into the clinics, and us talking to them when we remembered to talk to them about CRC screening. There was a second group that had a mailed FIT test, and then a third group that had a mailed FIT test, and then also a community health resource worker do some outreach to them. And on the next slide, you'll see the outcomes of what happened with these 3 cohorts in this tribal health clinic. If we depend on usual care for colorectal cancer screening, the rate that we see is on the very far left-hand side. If we depended on increased mail out of FIT testing alone, we saw that the percentage of participants receiving that accurate testing did increase back up from our usual care. But when we combined mail out of the FIT test and that outreach from the community health worker, we did see that additional step upwards in the percentage of participants that were screened appropriately for CRC. Next slide. The outcomes of the 165 kits that were returned, 39 actually had a positive result from their FIT test. So all of those 39 people were referred for colonoscopy. 23 of those 39 did complete the colonoscopy, and what they found later was 12 participants were found to have polyps. They were removed by scope, and 1 participant was diagnosed with colorectal cancer. And we give credit to these investigators that performed this study with the Tribal Health Clinic in calendar year 2020. Next slide. The other thing we want to ensure as we're still in this COVID-19 time period, and this was in the Gastroenterology Endoscopy Journal, that this can really pave a way forward for us to encourage the use of these non-invasive screening modalities. We know we can increase the use of mailed out FIT outreach programs and also establish those safe protocols for people that are returning and picking up those FIT tests to our clinics. We also want to ensure that we prioritize those positive FIT results so that we can get appropriate diagnostic colonoscopies in place for them, and then continue to do this community-based research where possible so we can track the outcomes and what we're doing with these FIT testings. Also utilizing that virtual social media platforms where possible. There's a lot of leveraging when we have Colorectal Cancer Month in the nation and in the state in combining with that message that goes out to our communities that we serve and our patients that we see. Next slide. And some of these benefits of these strategies, the CDC looked at this. Most importantly, in the prevention of colorectal cancer. We know that if we can increase the screening to about 80% of the current levels, we can reduce the number of people that are diagnosed with CRC by 22% by calendar year 2030. So that's a huge improvement. We can reduce the amount of deaths. So again, if we could increase screening overall to 80% from our current levels, we can reduce deaths from CRC by 33% in 2030. And remember again, this was the second costly death from cancer in the whole United States. Increase the 5-year survival rates. About 90% of adults with CRC are diagnosed at an early stage, and they live for 5 years or more, compared to only 14% that have that 5-year survival or more if you're diagnosed with late-stage cancer. So early detection and early-stage detection is key versus late-stage cancer detection. And ultimately, let's talk about saving the government money. And we talk about saving the government money from a Medicare perspective. It's really saving our money from our taxes too, because it's our tax base that goes in to support government programs like Medicare. But if we could increase the screening to 70% from our current levels, we could actually reduce the Medicare spending on colorectal cancer by $14 billion in 2050. And if we had those cost savings upon us, where else could we funnel some of those healthcare expenditures savings? And my vote would be for behavioral and mental health, but I have a very bias that we need to do more for behavioral and mental health rather than less. But I would appreciate some of that increased funding going towards those programs. Next slide. So the National Colorectal Cancer Roundtable really want to reignite all of us with screening our communities post-COVID and beyond. So we want to have these 4 aligning statements. We all agree and identify that CRC prevention is a public health priority. We also want to identify those people that will benefit most from colonoscopy. So start to looking at those risk stratification models based on family history, personal history, age, male sex, but safe screening as well that can occur with home stool-based tests. We saw some of the data already that helps support that patient adoption and outcomes of CRC screening can actually both benefit. And then that reigniting of the public message about all of these screening activities. How do we normalize this? That screening for CRC is a very usable, useful screening tool right now, and it's aligned with all of our other public health priorities that we have. Next slide. So I'm hoping today's overview of CRC and the United States Preventive Services Task Force recommendations have just given you some food for thought in terms of where you might stand today with your own patients, what you might need to do with them through telemedicine, through fit mailouts, through engaging your whole healthcare team around CRC screening, only because this is one of the cancers that has not bounced back up to pre-COVID screening rates. And if we allow the trajectory to keep going on, we are going to be seeing the presentation of patients being diagnosed with much later stages of CRC, and that gives us a whole missed opportunity of cost savings, but unfortunately, adverse patient outcomes too. So I hope I have given you enough food for thought in terms of ways to reach out to your patients, understanding of the updated recommendations with the U.S. Preventive Services Task Force recommendations for CRC screening, age 45 and upwards, with that grade B recommendation. And now we have an opportunity for a few minutes to dialogue. And if you had any questions specifically about the content that was introduced, or maybe even wanted to share some of your experiences yourselves in screening strategies in this COVID-19 time period, we could entertain that at this point in time.
Thank you so much, Dr. Iwancina. So while our attendees type their questions and we wait for reading them, let's use some couple of minutes to remind some of the things that we discussed at the beginning about CME. Remember, we will email you the CME and CE instructions and our YouTube link today. Please claim your certificate to complete the program evaluation. It will take just a moment and it will be of great help to us. After the webinar, page will open up that is gonna prompt a survey. Please fill out that survey. It will help us to update and to keep improving our cancer program. Remember that the activity code expires in 1 week. I'm going to show it to you in a couple of seconds. The recordings are going to be on our YouTube channel, and please feel free to send me any questions. If you come up with questions later on for Dr. Iwanchina, feel free to email them to me, and I'll be happy to send them to his way so he can answer them. So start typing, please. I'll show the activity code right now. Remember that to claim your certificate, you'll have to go to www.eeds.com, and the code for today is the one that you're seeing today, 36S as in Sam, E as in Echo, G as in Goat, O as in Oscar. And if you want to do it right now, you can go and use the QR code with your phones. And so let's see, we have a couple of questions. Well, what we have is it's thanks and kudos for the presentation. One of them says, thank you for the presentation. It's so nice to see the integration and value of CHWs. And so we are finding comments that are receiving this presentation with eagerness, and being very thankful and grateful for you sharing your experience with us. So again, if you have questions that come up later, feel free to send us an email and we'll make sure to get them answered for you. Another thing to remember is that after we close the webinar, there's going to be a survey that pops up. Please answer the questions. It'll help us a lot. And we will email you all the information about your CME and your certificate. And I think everybody understood everything. That's fantastic. So,
and Carmen and Stephanie, I wanted to say thank you again to you and to the Oregon Pacific Area Health Education Center, our Samaritan Cancer Resource Center. We have really great partnerships in our region. The PDF handouts were in the webinar itself, so feel free to utilize them. And I did give credit to my resources from the CDC, Dr. Foy's presentation, and the different JAMA articles for their help in putting this presentation together. So thank you so much.
Thank you.
Thank you, Dr. Iwanchina.
So, all right. Thanks to Dr. Iwanchina for sharing your time and knowledge with us. Thanks to all of our attendees for participating today on this sunny, beautiful day. And you have now completed the session and you may disconnect. Have a wonderful day. Goodbye.
Bye all.
Bye.